Hi, thanks a lot. Thanks for the invitation and happy to be here. Tough act to follow, and with a great presentation there. We're going to move from saving the lives of young women to saving the quality of life of old men. So a little change of pace here and talk a little bit about prostatic artery embolization, which is one of my great loves. I've probably done over 500 of these at UCLA, and really do get to change a lot of lives in a little bit different way than the last presentation. But you'll have a lot of super happy older men coming back to you in clinic, and that's nice to see too. So, by the way, nice logo. I like this logo, so I stole it for my title slide. We'll spend a few minutes talking a little bit about background and then go into the specifics of PAE. But to understand PAE and to be a good PAE practitioner, you have to understand a little bit about LUTS, or lower urinary tract symptoms. You have to be a bit of an amateur urologist as much as possible. And you have to recognize just how important and common a problem this is. So looking at lower urinary tract symptoms as we go up in age, we're talking 50% of men having LUTS by the time they reach retirement age. And so we're talking about millions and millions and millions of men. And I'm only a decade away from having this happen myself. So it's important to get good treatments for it. When you think about LUTS, though, you have to remember that it isn't just BPH or benign prostatic hyperplasia that's causing LUTS. You can have bladder problems like overactive bladder or neurogenic bladder. You can have urethral stricture. You can have chronic prostatitis. And you certainly don't want to miss cases of advanced prostate cancer, among other causes. So when you evaluate these patients in clinic, it really pays to take a good, careful history, as well as look at their imaging studies and their functional studies like cystoscopy and post-void residual. Sometimes they'll have urodynamics to get the full story, the same way a urologist would, and make an educated decision with the patient about what the most appropriate treatment is. And really, I try not to push my patients towards PAE. It kind of sells itself, honestly. So I really talk to them about what their other options are as well. And I think they really appreciate that, because they find, I think, that a lot of urologists just tell them whatever that specific urologist loves to do. So if they love to do UroLift, they're just telling patients about UroLift. But in my clinic, I try to tell them about everything. And the way to evaluate a patient is with this basic symptom score. It's called the IPSS, or International Prostate Symptom Score. And you can see it takes into account 7 different symptomatologies, including incomplete emptying and frequency, intermittency, urgency, weak stream, straining, and then how many times they're getting up at night. And that totals to a score between 0 and 35. And anything over 18 is severe. And those are mostly the patients that we're looking to help. So this particular patient had IPSS at 29, which is well into the severe range. And then you ask them this bother score, quality of life score, which is basically if you have to live the rest of your life with your urinary symptoms the way they are now, how would you feel about that? And that can score anywhere from delighted to terrible. And most of the time we're looking to treat people who are in the 4 to 6 range on their quality of life, meaning their quality of life is not that great at the moment. So let's try to help them. And just a quick look at a coronal CT image, just so we can have a quick look at the anatomy. Prostate sits right here, kind of central in the low pelvis, just beneath the bladder. The prostate often bulges up a little bit. That's called a median lobe, bulging up into the bladder. This patient has an indwelling Foley catheter, which gives you a marker as to where the urethra is. Really, the urethra is passing right through the center of that prostate. So you can imagine how, as the prostate enlarges and this BPH adenoma process is occurring, it's going to bulge into the urethral lumen and basically compress the lumen, restricting urination in the kidneys up above. And then just showing just how vascular the prostate can be. This is just a AP angiogram, kind of the same projection as this coronal. And you see the prostate lighting up like a light bulb. So we take advantage of that in our PAE procedure. So let's first go through a couple of the existing treatment options out there. And they have some cool little videos here. It looks kind of like Star Wars. This is what a TURP looks like. So they're doing this through a resectoscope, go through the penis with this scope, and then they use this coring element that uses bipolar cautery to basically shave away these fragments of the prostate, and then they basically suck those fragments out. And so you can see as they do that, they're creating a larger channel for the urine to pass out. And so this is actually a super effective procedure. And I always tell my patients that this is still the gold standard, and there's a reason for that, because it works really, really well in improving urination. But it does require at least a night in the hospital. It requires general anesthesia. It requires a few days of a Foley catheter. And there are some complications with it, including most patients developing retrograde ejaculation. Basically, they lose the ability to ejaculate outwards. It goes up into the bladder instead. Urethral strictures, erectile dysfunction, major bleeding episodes, and even permanent urinary incontinence can be complications of this procedure. And so a lot of men get offered this and really don't want to take these risks, or maybe they're not severe enough to want to take these risks. And so a lot of those patients will look for other options. But the outcomes, if you do have it and you don't have one of these complications, are terrific. On that IPSS scale that goes from 0 to 35, you see an average improvement of 15 points, which is terrific. The quality of life improves by 3.5 points on average. So that's really making a big difference in people's lives. And the peak flow and post-void residual measurements are greatly improved as well. And it's a durable treatment. So there's good things about TURP, and I always tell my patients that, even though there are the downsides. For larger prostates, TURP is no longer an option. So if your prostate's over 80 to 100 cc's, you only have a couple options. One is a holmium laser enucleation of the prostate, which I don't have time to go into now, but it's out there. And then there's simple prostatectomy, which is usually done by robotic assistance like you're seeing here nowadays. But essentially, they do a surgery to remove the adenoma, basically the entire central portion of the prostate gland. And as you can imagine, this is they are taking that big adenoma right out of there. And what's left is a giant channel for urine to empty out of the bladder. So as you might imagine, it's very effective, but downsides even more than TURP. General anesthesia, multiple day hospital stay, Foley catheter, sometimes for a couple of weeks. IPSS improvements are terrific, 18 to 20 points. Quality of life is also great because the urination is, as you might imagine, very, very good after having your prostate removed. And then, of course, what's the bad side are the complications. You get retrograde ejaculation in almost all cases. Blood loss is more frequent. UTI or sepsis, not too uncommon. Urinary incontinence is more common. Bladder neck contracture, and even mortality. So as you might imagine, a reasonable number of men are looking for alternatives. And I don't have time to go into all the alternatives, but I'll just present one, and that's called UroLift. The urologists have been very busy trying to develop less invasive options to take care of BPH. And this is one that's been around for a while now, where they essentially insert these tensioning anchors into the urethra and basically try to pin the urethra up against the prostate wall to kind of pin the urethra open to allow you to urinate better. And it has some advantages because you maintain ejaculation with this procedure. It doesn't require as much anesthesia, often doesn't require a Foley catheter, but it's pretty limited. Only works for small prostates, can't work with the median lobe. The recurrence rates are relatively high. The IPSS improvement is not that great. And there are some complications, including having incrustation of those implants. And so I see a lot of failed UroLift patients in my clinic, and it is not a perfect procedure by any means, especially because of its poor durability. And so there's limits, but it is a nice option for men with small prostates. And that brings us to PAE. And PAE has a pretty simple rationale. Since the prostate is hypervascular and it has blood supply from the prostatic arteries, we can basically super select and embolize those arteries and get partial ischemic necrosis of the prostate gland. So if you see the prostate looking pretty big here, this is a day or two after embolization. You'll see these kind of necrotic cavities within the prostate. That actually turns pretty quickly into just a smaller prostate as that necrotic tissue gets reabsorbed. And as the prostate shrinks, there's less compression on the urethra and the LUTS improves. And, we have a long history of embolizing organs to reduce their size, uterine fibroids, spleens, kidneys, liver cancers, et cetera. So there's no surprise that the prostate would shrink after blocking its blood flow. And here's the basic technique. This is what it looks like during a procedure, either femoral or radial access. I'm doing a lot of both. We do internal iliac artery angiograms, and this is a 45-degree ipsilateral oblique, meaning we swing the image intensifier over to a fairly oblique angle so that we can open up all the arteries of the pelvis. And these arteries going off to the side of the screen here are the gluteal arteries. You can see those are the biggest arteries in the pelvis. And then these smaller arteries that are going more towards the left side of the screen here are going towards the center of the pelvis. And that includes the prostate here right in the middle. The origin of those prostatic arteries is variable, so it makes it a tricky procedure. And you can also see just how small these prostate arteries are. So here's the bladder artery up above, and then the microcatheter right now is within the prostate artery. That's a 0.67 millimeter microcatheter, 2 French. So it's only 2/3 of a millimeter, and you can see it's filling almost the entire artery size. So often they're less than a millimeter in size, which makes this kind of a tricky procedure. But once you get into it, you can see the injection of contrast is leading to this very hypervascular blush. And once we're in there, we will confirm our position with a variety of views, or you can do a cone beam CT, which I'll show in a minute. And then we go ahead and embolize. And usually we use microspheres. There's a variety of types of microspheres. They all seem to work similarly well. They're bland. They don't carry any chemo or anything else. This is just meant to obstruct blood flow. And In some cases, we may also use coils either to redirect flow towards the prostate or to help improve durability of the occlusion by adding some coils behind the beads. We're experimenting with some of that right now as well. And once you're done, basically you see no more flow in the prostate artery, and then you'll usually reshoot an iliac artery angiogram to confirm that the rest of your organs maintain their blood supply, because certainly the goal is only to embolize the prostate and nothing else. So why would we do a PAE? What's the advantages over surgery? Well, first, and one of the most important, is that it's basically the bigger the better. There's no limit on prostate size, whereas TURP and UroLift and Rezum and a lot of these other urologic procedures really only work for prostates up to about 80 to 100 cc's. And there's very few options for patients with larger prostates, but we can treat 200, 300, 400 cc prostates with PAE, and we've actually studied those patients. They do terrific. What else? Well, it's done as an outpatient. They come and go the same day. It's all done under conscious sedation or even local anesthetic. I have some patients who just want to chat with me and watch the procedure on our monitor on the wall while we're doing it. It doesn't cause even a little bit of pain. It's completely painless during the procedure, aside from the bit of lidocaine in the skin at the start. The recovery is quick, usually just a few days, where they will get some symptoms after a PAE. They'll get burning with urination, some pain in the pelvis, sometimes a little blood in the urine, sometimes frequent urination, but those all go away within a few days, and certainly the recovery is easier than surgery. And perhaps most importantly, the morbidity of PAE is quite low. There's no impotence, there's no incontinence, you don't need a Foley catheter, ejaculation is almost always preserved, and blood loss is minimal. So a lot of positives there. And there's an on-label indication for several of the embolic spheres with the FDA for the last 5 or 6 years. So to summarize the PAE, it's done as an outpatient, moderate sedation, no Foley. Their ideal candidates are going to have large prostates, really the bigger the better. My minimum is 50 cc's for me to consider a PAE, but I really prefer them to be over 80 cc's. Patients with hematuria or blood in the urine, as you might imagine, if that hematuria is coming from the prostate, blocking the prostate's blood supply is a great way to treat that. And in fact, I've got a patient we're transferring down from an outside hospital now for exactly that reason. They have to keep him on constant bladder irrigation because he's bleeding so much, and they've already tried trying to treat it through the scope with a variety of cauterization methods, hasn't worked, but an embo can take care of that right away. We can treat median lobes without any problem. It preserves sexual function, and it's fine in poor surgical candidates. So I have patients that are 90 years old. Sometimes they don't qualify for most of the surgeries. No urologist wants to touch them, but they can come and get a PAE with essentially zero morbidity. Blood thinner is also fine. We can do this patients on Coumadin or heparin or Eliquis or Plavix or aspirin, because we can either do a radial approach or use a closure device at the femoral, and bleeding risk remains quite low. Most important, what are the outcomes? Well, it's good. I'm not going to say it's as good as TURP. Usually what I quote my patients is about 80% of men are going to significantly improve after a PAE. And the IPSS improvement's about 10 to 15 points, quality of life improvement 2 to 4 points. These are not as good as surgery, but comparable or better to the minimally invasive surgical options. And the complications, really rare. And you can look at those, but those are pretty mild and very uncommon. And the non-target embolization, which would be the most severe complication, is very rare. Biggest problems with PAE is about 20% of men don't respond, just don't have a lot of improvement, either because their bladder doesn't work very well or their prostate doesn't shrink well enough. And then there is a fairly high retreatment rate where the prostate can resupply from other vessels and eventually their symptoms can come back. So there's the patient selection from our own SIR consensus statement. Big prostate size, that's good. Indwelling Foley is great. 80% of the time we can get that Foley out after a PAE. Prostatic hematuria, sexual function, advanced age is no problem. Blood thinner is no problem. But look out for small prostates and patients with really severe obstruction where they may benefit from surgery more than a PAE. A quick case, this is how a lot of my cases start. Patients find me online, they find my YouTube video, whatever the case may be, and they start sending me emails. And these patients are often very involved in their own care, and it's email after email after email after email after email after email after email. This is before the PAE. We haven't even gotten to a clinic visit yet. But I take my time and I really try to respond to these patients and answer their questions as much as possible. And they really appreciate that. I think it builds a lot of trust. It does take a lot of time. So there's pluses and minuses. This particular guy, he was self-referred, had a severe IPSS score, pretty severe quality of life, pretty typical symptom complex. He had failed medical therapy and refused surgery. So he's really the ideal candidate. His post-void residual, about 174 cc's. So that's in the abnormal range. A normal would be under 100 cc's. So certainly he's got some problems with urination. We often start with a CT angiogram. This is a CTA to look at the prostate. His prostate volume measured out at 88 cc, so a pretty big prostate. There's a look at the median lobe bulging into the bladder. The bladder itself is distended and trabeculated, meaning thickened from basically the muscular wall building up from having to squeeze so hard to try to get the urine out. You can see that thick bladder wall there. And then the prostatic arteries, we can even see on CTA. We can detect where those are and where they're coming from, so it helps guide us during the embolization. We usually get access under ultrasound with a micropuncture set, put in a 6 French sheath. There's a look at the common femoral artery under ultrasound. Start with a little pelvic aortogram just to get to the lay of the land, and then go ahead and get into the internal iliac artery. And once you get into that, you shoot this ipsilateral oblique, you want to try to find the prostatic arteries. And the clue is often looking for the arteries that cross over the main trunk of the obturator. Here's the obturator with the distal fork. You can see there's a few branches. They're crossing over that obturator to pass to the anteromedial pelvis. So this is where the prostate's going to sit. And we look for arteries that are going in that direction. And actually, there's a few in this case, which made it a bit complicated. 3 arteries are kind of headed that direction. In that case, we often super select each one and check each one. So here was the first one. This is in that same oblique, and now we can see that artery supplying the prostate and starting to see that blush. This is an example of a cone beam CT. As we inject contrast, we can see the prostate lighting up on cone beam to confirm that we're in the right place. So this is one of the main prostatic arteries. Here's us doing our embolization. Try to do an embolization both proximal and distal within the artery. That's called perfected technique to help really get as many beads in there as we can and block the blood flow to a really extreme degree. The second branch also confirmed going to prostate. And this happens about 20% of the time that you'll have a second supply. And sure enough, the cone beam CT proved that there was a supply from a second branch as well. So got into that one, embolized that as well. And then we got into the third branch, and this is what a typical rectal supply looks like. So this is middle rectal artery. You can see the branch is more vertical going down towards the anus. Branches are overlapping with the air bubble of the rectum on the x-ray. And so this we did not embolize. After doing the embolization on that side, we do a post-embo angiogram. You can see those arteries are missing. There's no more prostatic blush. That's a successful embolization. The rest of the arteries are preserved. Go to the ipsilateral side. I usually use a Simmons catheter, basically a reverse curve catheter, pull that down into the ipsilateral oblique and shoot the same type of run. And this time we have 2 branches coming and crossing that main trunk of the obturator and passing towards the anteromedial pelvis where the prostate should sit. So this one, we investigated both of those 2 branches. And there's the first one, which ended up being the main supply, big prostate blush, cone beam CT, lighting up in the right side of the prostate. Go ahead and embolize that. And then a second supply as well, just a small accessory to the capsule. And that's often the case that you'll have a capsular supply. So we try to take that out, even though it isn't contributing a lot, but more because we expect it might increase recurrence rates if we don't treat it. So we try to take care of that while we're at it. Post-embolization angiogram looks good. Non-target branches were preserved. Do an angioseal, which is a plug-based closure device on the way out. He goes home 2 to 3 hours later. Procedure takes a couple hours. It does take a little time since you have to super select a lot. We embolize 4 branches in that procedure, but the guy comes back super happy. 3 months later, his LUTS is much improved. His IPSS is down to 6. His post-void residual is better, and he, most importantly, has an improved quality of life. So I see a lot of these happy guys, and this will happen and it will last often for years. Average durability about 5 to 6 years for a PAE based on data out of Brazil and Portugal. So we'll wrap it up. It's good to know all the treatment options for BPH and LUTS. Try to become as much of a urologist as you can. If you want to treat patients with BPH, you're going to be their best advocate, because sometimes the urologists aren't being their best advocate. They're just wanting to do procedures on them that they do. But if you offer them the whole suite, patients will really have a lot of trust in you. So do keep in mind that just because we have a hammer, not everything is a nail. I send a lot of patients to urology. They're not great candidates for PAE. Either their prostate's too small, their obstruction's too severe, they have prostate cancer, etc. And keep an eye on the minimally invasive surgical techniques are missed or rapidly evolving. Aquablation is coming out, iTind, which is a stent-based urethral device. So there's a lot of things that are changing in this world. But PAE is super effective. It works great for large prostates, for hematuria. Patients who are catheter dependent are some of my favorites because they're so happy to have that Foley catheter out, and patients who are poor surgical candidates can still get a PAE. So we'll stop it there. And again, thanks for having me.